Well, but it just, of course, if I was a student and do this as close to me as he did, I would be concerned as well. Yeah.
I mean, is that pretty rural?
You know, it's actually fairly costly. And right now it's somewhat rural. So, this hospital that there was, it's a mission hospital. They're pretty somewhat isolated from the city and the budget. You know, it's severe as the infection is and everything, it's not easily transmitted. People think it's not like really airborne, you have to interact with fluids, so it's
What is it?
fluids, so
Any fluid like the
yeah. Just like, so it's, and I don't know the extent of when it's transmittable. It's like there has to be symptoms first, or it's transmittable without symptoms.
Worse is when people don't even know that.
Yeah, there's pushing. So I'm looking forward to seeing those students when they come back after this class, just to mess with them a little bit. Come to my desk.
They need to report to the fifth floor.
Yeah, the GNL, yeah. What's funny because the director, the TV director of the ABC program is Dr. Kaiser. It's kind of authority too, and so if it were to happen here, he would be the one kind of like overseeing. Sorry. And he is their direct mentor for their location. So
You send this.
yeah, well, he sent them. It was like one of those things, emailed us about it. Back with panicking. It's pain right now. There's not even a suggestion of how to get back to it.
Well, what is the purpose of their trip?
Their purpose, so they're first year medical students, so they're going training to see how medicine is practiced in resource setting. It's to do a research project, usually lab-based, and presents a poster on their findings.
Interesting. Yes. And there were people that used to recovery centers, and they brought it with them. So Thursday.
Yeah.
I mean, obviously, yeah, it's just Thursday. Okay.
Yeah, some of our medical students can figure out to get engaged and they come back and help with our tracking. But I don't work with a small portion of the medical students, those that are specifically interested in full. But then we also have another round of the team engagement tracker, which is more public rural health.
Well, and I think that's good. There's nothing wrong with that. There's things that some people coast. Okay. How to do the succession.
You don't have to run.
Last year,
How did that?
What happened to the fans in? That's what I'm really asking.
and then yeah,
The rumor I heard is
from our
the compressor.
graduates.
Or they found the inmate up there.
I know we've had marketing statements as well.
Good since I got there. They had raised
Avenues. I mean, it's a good fire.
Why is this one so low? And when I sit in my office, that one up there, she can make that thing
Well, they're not
scream.
in front of the mic yet, so.
No, when we listen to it, sometimes I can't hear it.
Oh, true.
Holding on to do it, we say that.
Something is up. You try to hear this crap. You can't hear that.
No, that didn't work.
And it's right around.
I think this is just for the.
Yeah,
Because he's been here for three.
yeah.
Yeah, that's what I'm saying. Internally, they may be, computer is, got another.
One of the other, but there's so much in between that I haven't seen. Because like you're always on the main street, you're always on Broadway, Wall, Harborside, OP. Maybe yeah, those are like real.
5 little bulbs in there.
Middle neighborhoods and things like that.
Well, I tell you like this, right?
Have a good day.
There it is.
So I'm just curious about this little clip. Point at this microphone. Yeah. Here's what I'm telling you. All right. Good afternoon, everyone. Welcome to today's Lunch and Learn. We have Dr. Serpa with us. He is coming to us from the Baylor College of Medicine, and he has worked with the Thomas Street Health Clinic for over 10 years. His interests include HIV and STD research, and he's here today to talk to us a little bit more about that. So without further ado, Dr. Alvarez, thank you.
Well, thank you very much for inviting me. It's really a privilege to come here and speak about, such an important topic, sexually transmitted diseases in HIV, in people living with HIV. And as Bradley said, I've been working at Thomas Street Clinic since I was a fellow in 2005, and then joined the faculty. Been there for about 11 years now. And I also spend some of my time doing medical education. I'm currently the director for the Infectious Disease Fellowship Training Program at Baylor. And this is a topic that we usually review with our trainees, with our fellows. And I really find it fascinating. Hopefully, you will be able also to learn certain, the recent trends in sexually transmitted diseases in the United States, and also learn some pearls that I would like to share with you all. So for today, I would like to focus the lecture in 3 main objectives. The first one is I want to review the epidemiology of sexually transmitted diseases. And when I say epidemiology, it's mainly incidence rates of sexually transmitted diseases in the United States, with a focus, of course, on people living with HIV. The second topic is try to briefly review clinical presentations, diagnosis, or treatment of the most common sexually transmitted diseases. And for this lecture, I'm going to focus on three main topics. Number one, syphilis. Number two, gonorrhea. And number three, chlamydia. And then we are going to finish this lecture with probably 3 or 4 slides, trying to understand, trying to identify the potential risk factors that have been associated one way or another with the increase of sexually transmitted diseases in the United States. Again, I mean, this is the last objective is a sort of a controversial topic, but I would like just to give you some ideas. Of course, nothing is set in stone, and this is an open topic for more discussion. So let me get started with the first objective, which is to review the epidemiology of sexually transmitted diseases. These are some numbers that I brought that I think are very important for us to know exactly what the status of STDs in the United States is. You can see that chlamydia infections have become the most common STD in the United States. There are more than 1.5 million cases which were diagnosed in 2017. And this represented an increase of about 23% when compared with the rates in 2013. Gonorrhea cases, more than 500,000 cases in the U.S., and this represented 67% increase compared with 2013. And syphilis, in syphilis here, I'm just trying to focus on primary and secondary syphilis, which are the early stages of syphilis, the more contagious one. And in the U.S., there were about slightly over 30,000 cases in 2017. And unfortunately, this represented a 76% increase when you compare it with the rates in 2013. Here in this table, I put together some numbers. Basically, the total number of cases of STDs and also the rates of STDs. So you can see, let's start with the primary and secondary syphilis. You can see, I mean, you can go from 2008 all the way to 2017, and it's very obvious what is going on. There is a clear increase, steady increase in the number of cases, and also in the rates of primary and secondary syphilis in the U.S. The situation is very similar when you consider early latent syphilis, and we'll talk a little bit more what primary, secondary, early latent, and late latent is in the next few slides, and also when you take into account all the cases of syphilis. Clearly, there is a steady increase in the number of cases and rates. The situation, unfortunately, is very similar for the other two STDs that we're focusing on today, gonorrhea and chlamydia. And in gonorrhea, let me start with gonorrhea before I move to chlamydia. In gonorrhea, you can also see the number of cases and the number of rates. Clearly, there's been an increase in the last 5-6 years. I want to point your attention to this year, 2012. And in my view is where, and I'll show you some graphs for you to see how on that year the rates and the number of cases really took off. Does anyone know what happened in 2012? Exactly. This is when HIV pre-exposure prophylaxis was implemented. And just to give you an idea, this is what's going on with HIV incidence. You can see that over the last 6-7 years, because I'm also showing you data for 2017, the number of cases has remained relatively stable. These are estimated numbers from the CDC. All these numbers, by the way, are from CDC. CDC has a fantastic website. I would recommend all of you to review it. If you want to learn something about STDs, I think the CDC website is the place to go. And you can see how the incidence rates have remained relatively stable. In 2017, slightly over 38,000 new HIV diagnoses in the country. Now, let me just show you specifically for chlamydia, gonorrhea, and syphilis, and try to break down these numbers into geographical areas. So you have an idea. And unfortunately, I show you some numbers that I'm sure you are very familiar with, but kind of call your attention about what's going on in the southern United States. Thank you. So let's start with chlamydia. So here is the distribution of cases of chlamydia according to sex. So you can see that in the United States, the majority of cases have been reported in women. And why is that? This is basically an expected phenomenon. What happens is, if you read the CDC guidelines, the recommendation is to screen all women younger than 25 years of age who are sexually active, and also screen older women who have certain risk factors. So in other words, the rate of screening, of testing for gonorrhea in this population is markedly high. When you compare Medicaid rates of screening for chlamydia, or even commercial insurance rates of screening for chlamydia, the numbers are going up and up. That means that we are testing more and more. That is the right way to do. And that is perhaps what's explaining why the women is the most affected gender for chlamydia infections. But you can see, I mean, even then there is an there is an increase in the rates of chlamydia infections in both genders. And this is the number for 2017. The rate was 529 cases per 100,000 population. This is very unfortunate. We are here south. We are at the top. So southern states in the United States have the highest incidence of chlamydia infections. This is very unfortunate. If you want to go to the state level, here we are, and the rate for Texas is 544 cases per 100,000 population. I mean, you can see in all these southern states, you can see all the rates, but also Alaska, 800, very interesting there. And I'm not even mentioning DC. The rate in DC is 1,337 cases per 100,000 population. But anyway, so situation does not look good in southern states in terms of chlamydia infections. For gonorrhea, it's happening a similar phenomenon. You can see the number of cases. This is all the way down to 1941. And let me call your attention. In 2009, there was a record low number of cases. We were very happy. We thought that we were doing very well. See what happened then. After that, the rates started going up and up and up, to the point that in 2017, the incidence rate for gonorrhea is 172 cases per 100,000 population, and very similar to chlamydia. Look who is at the top. Us. So southern states are basically leading or having the highest incidence rate for gonorrhea cases. This is the incidence rate for southern states, 194, above the national rate. Once again, if you want to know the rates for our state, these are the numbers. The rate in Texas is 170 cases per 100,000 population. Now, syphilis. And in syphilis, it's very important to try to make a differentiation in terms of the stage of syphilis. Because primary and secondary syphilis are relatively easy to diagnose. Even the early latent could be relatively easy to diagnose. The late latent, which is included in total cases of syphilis, is a little bit more difficult to quantify. But even then, I mean, CDC presents very nice data showing that the number of cases for, and here it's difficult to see because the scale, I think is the correct thing. I mean, they did the same scale for all the STDs, so we have, a better idea. But I would have preferred to have a different scale for this graph. But anyway, the conclusion is that the number of cases, as I show you in the first table, table that was my second slide, for primary and secondary syphilis is increasing, to the point that in 2017, the incidence rate of primary and secondary syphilis was 9.5 cases per 100,000 population. And, well, here we're not on the first place, luckily, but we're second. So see, these are west states, and south, we are second. We're here. So in the southern states of the country, the incidence rate for primary and secondary syphilis is 9.7 cases per 100,000 population. And you can see here, where the scale is different, you can clearly see the upward trend. And for Texas, you can see the incidence rate for our state, and you can compare it with other southern states. You can also compare it, with other, northeast or basically some middle states. Now, let me spend a few more minutes on syphilis because I think syphilis is tremendously important. When you look at sexual preferences of cases of syphilis, you see that at the very, very top, the majority of cases of syphilis are seen among men who have sex with men. You can see here in blue, in light blue, is heterofilous men who have sex with women, and at the bottom is women. But let me just remind you that for the three groups, the number of cases is going up. And this is a slide showing you distribution between HIV negative and people living with HIV and syphilis. And you see that among men who have sex with men, 45% of them are actually HIV positive. Among women, this number is relatively low. Only 4% of women infected with syphilis had HIV. And among men who have sex with women is only 8%. So what's driving the increase in the number of syphilis cases is mostly people living with HIV who are MSM. Okay, so that's all what I wanted to tell you about epidemiology of STDs. I think the conclusion is that there continues to be a steady increase of all the sexually transmitted diseases, and by that I mean syphilis, gonorrhea, and chlamydia, over the last, I would say, at least 5 to 6 years. So here, I'm going to present 3 cases. One case for syphilis, one for gonorrhea, and another one for chlamydia. Again, this is not a very extensive review of clinical symptoms and diagnosis and treatment, but at least I want to touch base on certain points that I think are very important for you to remember. I am sure that in your practice you do this every day, but it's always a good idea to discuss certain controversies. Remember, especially in syphilis, there are many gray areas. So I'm going to tell you something, but you could tell me, well, Dr. Serpa, there has been some study questioning what you are saying, and it's very true. In syphilis, we need to keep in mind that there is still much to do. However, I'm going to try to focus on the CDC recommendations. So in the case number 1, we have a 24-year-old man who has HIV. His CD4 count is 264. This is a newly diagnosed. And his HIV RNA viral load is 85,000 copies. He denies any recent trouble. He has never been incarcerated or been homeless. And he's currently sexually active with a male partner. He does not use condoms. Does that remind you of anybody? It's a very common presentation of our patient population. Very, very common. And he reports a painless ulcer in his penis about 4 weeks prior to presentation. When you examine him, he is afebrile, but he has a diffuse maculopapular skin rash affecting soles and palms. And he also has some small cervical and inguinal lymphadenopathies. You order what I like to call STD screen, which is basically syphilis, gonorrhea, and chlamydia, genitals and extragenital sites. And we'll mention a few more about extragenital testing in the next few slides. But the serum RPR was positive, 1 to 32. Remember, the serum, the RPR, is a non-treponemal test, and that was confirmed by a treponemal test called FTA-ABS. So fairly supportive diagnosis of syphilis. And the gonorrhea and chlamydia nucleic acid amplification testing was negative. So the diagnosis was syphilis, and we're going to go a little bit further. It's probably not enough to tell me, well, Dr. Serpa, this is syphilis. Next step is, okay, which stage of syphilis? And this is important because this is going to tell you what the treatment is. There is a difference between early and late syphilis. But let's try to focus on the stages of syphilis. So we have the early syphilis, and the early syphilis include primary, secondary, and early latent syphilis. The primary, as you all know, is genital or extragenital chancre that happens at the site of inoculation. It usually happens about 2 to 3 weeks after inoculation, but the range is 10 to 90 days. Now, description of a chancre is basically a single, painless, hipped up ulcer with a clean base. Having said that, in real life, you could also see patients with painful lesions and it's still syphilis. But I guess for test-taking purposes, is painless. But in real life, even if it is painful, I would not completely rule out syphilis. There are some traditionally painful genital lesions. One of them is chancroid, which is extremely rare, has become extremely rare in the United States. And the other one, which is very common, is genital herpes. Okay? So if it is, once again, if it is painless, syphilis, if it is painful, genital herpes or chancroid. However, in real life, be aware that there are cases presenting with painful ulcers that are actually syphilis. Right. Secondary syphilis includes a myriad of clinical symptoms and signs. The most common one are fevers, malaise, lymphadenopathies, skin rash, patchy alopecia. And I want to mention something. Secondary syphilis can also cause mild hepatitis. It can cause a transient mild elevation of the transaminases, and typically there is an elevation of the alkaline phosphatase. So be aware if you have a patient presenting with secondary syphilis and you do the blood work, take a look of the liver function tests. You might see certain abnormalities that after treatment resolve. Secondary syphilis typically occur after 4 to 10 weeks after the inoculation, after the infection. And the other one is the early latent. What's the difference between primary, secondary, and early latent? Early latent, the patient does not have any symptoms. It's completely asymptomatic. It is usually has a positive serology, and it has happened within 1 year. How do you know that? Because if you are working with the patient population same as us at Thomas Street, we screen our patients every 6 to 12 months, and you could tell when the patient became positive. Sometimes you can't, and when you can't, it's probably better to call it late latent, although the strict definition of late latent is greater than a year of infection. Again, no symptoms, positive serology. Some textbooks also use the term syphilis of unknown duration. For practical purposes, that fits into the late latent syphilis. Okay? And there is something that we don't see very often nowadays, which is the tertiary syphilis. Usually happens after many years after infection, and includes several manifestations, including cardiovascular syphilis. This is aortitis, aortic insufficiency, and these historically famous gummas that are chronic inflammatory tissue that can happen in CNS or in central nervous system or non-central nervous system locations. So that's the typical primary syphilis. Remember, it's hipped up borders, clean base, and painless. Chancre can also happen in extragenital places. It can happen, in the lips. It can also happen in the oral mucosa or even in the palate. This is a typical skin rash of secondary syphilis. These grayish maculopapular skin rash in palms and soles, also in the trunk and sometimes in the extremities as well. Now, neurosyphilis. There's been a lot of controversy, and this is still a controversial topic. Okay? But as I mentioned, I'm going to stick to CDC recommendations. When do you perform a lumbar puncture to rule out neurosyphilis? There are only 3 indications. Number 1 is when there are neurological signs and symptoms. The most common one is headaches, visual abnormalities. When there's been treatment failure, and I will define treatment failure later, or in cases of tertiary syphilis. Those 3 indications, lumbar puncture should be performed. And keep in mind that neurosyphilis can happen at any stage of syphilis, not just late stage. It can even happen at early stages of syphilis. So some experts do or present a differentiation between early neurosyphilis and late neurosyphilis. And early neurosyphilis happens months to years after infection and include meningitis and meningovascular syphilis. What is this? So these patients have typical meningitis symptoms. They have fever, they have headaches, they have nuchal rigidity. You do a lumbar puncture, you find pleocytosis, and I'll tell you what else to look for. Or they can present with ischemic strokes. So that is early neurosyphilis. Now, keep in mind that syphilis can also go to the eye and to the ear. So ocular and otic syphilis should also be considered as neurosyphilis. And the late neurosyphilis that we don't probably see very much nowadays happens after decades of infection. That includes the general paresis. This is basically a dementia, personality changes, tabes dorsalis, which is a chronic shooting pain with ataxia, and also the CNS gammas, as I mentioned before. But these are late neurosyphilis and very rarely seen nowadays. The diagnosis, if it is primary, so you do a dark field microscopy. Why is this? Because most of these patients will have a negative serologic testing. In other words, if you catch the infection early, you're not giving enough time for the patient to develop an immune response, and the serology will be negative. It is probably better, in our clinic, it's relatively difficult to get a dark field. So sometimes we test, but we also treat empirically. And this is a teaching point. In these patients, you should probably not delay, because if you say, come back, and in your second visit we'll decide, they won't come back. And you will lose the perfect opportunity to break the transmission cycle. Secondary, secondary, early latent, and late latent almost always have a positive serology. There is something called a Poisson phenomenon. Is basically when there is a very high concentration of antibody in the serum that actually renders the test negative. But again, when in doubt, it is probably better to treat and then find out. Tertiary, you can do serology, but these patients can have reversion. In other words, the serology can become negative, and you can do biopsies. Neurosyphilis, when you do your lumbar puncture, you have to order a VDRL test. Don't order RPR because the RPR cannot be done in CSF. Well, it can be done, but there are some logistical problems and some sensitivity and specificity problems. If you're going to order in CSF, it's VDRL. The only problem is that it is only about 50-55% sensitive. So half of your cases with neurosyphilis will have a negative CSF VDRL. In that case, you move to the second step. You check the number of white blood cells in the cerebrospinal fluid. The cutoff are 5 in HIV negative and 20 in HIV positive. Why? Because remember, HIV itself can give you pleocytosis. Pleocytosis is an increase in the number of white blood cell count in the cerebrospinal fluid. So if you do this cutoff, you will probably increase in sensitivity, but you will be decreasing a lot your specificity. So the cutoff for HIV is probably 20. And then the third step is looking at the CSF protein. The treatment is relatively simple. If it is primary, secondary, or early latent, benzathine, penicillin, single dose. The alternative is doxycycline. If it is late latent, is benzathine, penicillin, IM, weekly, times 3, and the alternative is doxycycline. And here is the point that I wanted to tell you. How do you know that a patient has responded to therapy? And the way to define treatment success is when you have a 4-fold or a 2 dilution decrease in the titer of the non-treponemal test. Now you could ask me, okay, in how long, Dr. Serpa? And I will say that is a difficult question. Most people will say 12 months. However, there are some data that in people living with HIV, probably we need to wait up to 24 months to make the, one more time. If your patient got lost to care and you couldn't follow up the RPRs, and the patient showed up after, let's say, 2 years with a positive RPR, and you don't know how to compare, again, you evaluate risk factors. When in doubt, please treat. The opposite, so if you don't get a 4-fold decrease or a 2 dilution decrease, will be treatment failure. In most, probably 90% of the time of treatment failure, the reason is reinfection. So the treatment for neurosyphilis is different. It's crystalline penicillin G IV for 10 to 14 days. There is an alternative. You can still use procaine penicillin G IN. So if you don't really like your patient or you really want to scare him, just give him this and you'll see what happens. Now, this is a very important point. Treatment of syphilis in pregnant is penicillin. There is no alternative. Even if the patient is allergic to penicillin, you have to do desensitization. No alternative for penicillin. I'm sorry, for the use of penicillin in pregnant women. Okay, this is a paper that we published a couple of years ago, and actually Dr. White, who was my mentor, we were honored that he wrote the editorial for this paper. And this is basically comparing 1 dose of benzathine penicillin versus 3 doses of benzathine penicillin IM, intramuscular, in cases of early syphilis. As I told you, CDC recommends 1 dose. There were some observational data suggesting that maybe we needed 3 doses for people living with HIV. In this trial, we demonstrated that 1 dose was equivalent, even though the absolute numbers are slightly lower, but did not reach statistical significance. So the bottom line is this. Treatment for syphilis is the same regardless of HIV status. Okay? Some observational studies have shown certain risk factors. One of them was a CD4 count below 350 or an RPR greater than 32. There was another paper, I think it was published in 2013 in Journal of Clinical Microbiology, where they found that the RPR cutoff was not really a risk factor for neurosyphilis. They found a cutoff of CD4 cells of less than 500, but they also found that having a positive viral load was a risk factor for neurosyphilis. And that's basically supported by this other paper that showed that antiretroviral therapy decreased the likelihood of neurosyphilis. So the case 2, so that's syphilis. We're going to move on now to gonorrhea. So in case 2, this is a 61-year-old male. He presented with several days of urethral discharge and dysuria. That's HIV. CD4 count is 432. The viral load is undetectable. He is on antiretroviral therapy, dolutegravir, tenofovir, emtricitabine, and he denies any fever, any skin rashes, any adenopathies, any sore throat, any rectal pain, or any diarrhea. He has been diagnosed and treated for gonorrhea at least 3 times in the past. The last episode was 6 months ago, and this is what he received. He received ceftriaxone, 250 milligrams IM times 1, and azithromycin, 1 gram PO times 1. On exam, he is uncircumcised, and he has a profuse milky urethral discharge. So the serum RPR was negative, but the gonorrhea nucleic acid amplification testing in urine was positive. The chlamydia was negative. And the culture grew Neisseria gonorrhea, and it was sensitive to ceftriaxone. And I'll tell you why I'm presenting these results here. We don't usually culture, but in this case, there was some concerns about potential, not just resistance to ceftriaxone, but maybe what the CDC is calling slightly high minimum inhibitory concentrations, MIC, of the bacteria, which it means is that the antibiotic is still sensitive, but what you see is that it's requiring a little bit more antibiotic to treat it, and that is an early sign of resistance coming up in the future. So gonorrhea can cause very different syndromes. It can cause urethritis, cervicitis, proctitis, pharyngitis, conjunctivitis, and this syndrome disseminated gonococcal infection. We just had one case of this condition at Bentop. It was in a patient with HIV. And these patients are sick. I mean, the patients with this disseminated, well, first of all, this disseminated gonococcal infection is not very common, but when it happens, patients are really sick. He was febrile, he had a skin rash, and the skin rash is typically described as petechial or pustular. He had tenosynovitis, and he had arthritis of the right knee, if I'm not mistaken. And the blood culture grew Neisseria gonorrhea. But anyway, the most common presentation will be these two at the top, urethritis and cervicitis. That's the urethritis, cervicitis. This is the skin lesion that I was describing. Okay, so the diagnosis of gonorrhea is mainly nucleic acid amplification testing. You can do culture, you can do gram stain of the discharge, and that's acceptable. But by far, I have to say that nucleic acid amplification testing is what we do nowadays. So, so the nucleic acid amplification testing can be used in different types of specimens. It can be used in urine. That's probably the preferred specimen for male. It can be done in cervix, although vaginal swabs are an acceptable and perhaps the preferred method of diagnosis in women. And actually, these vaginal swabs can be done by either a provider or it can be done as self-collected specimen. The sensitivity and specificity is very similar. Again, if you don't like your patient too much, you can do this. You can swab the urethra, but the patient cannot really hate you. And then the FDA is not approved by the FDA, but still we do it. We also test gonorrhea in rectal specimens and in pharyngeal specimens. Be aware that there are Neisseria species in the throat, so be careful about that. And